Hey, future nurses, welcome back to Smart Scrubs. I'm your fellow nurse, and today we are tackling electrolytes, a huge NCLEX topic that can feel overwhelming sometimes, but don't stress. We are diving into sodium, potassium, chloride, magnesium, calcium, and phosphate with simple mnemonics, fun analogics, and tricks to make it stick. By the end, you will spot imbalances like pro and ace those NCLEX questions. Grab a pen, hit that subscribe button, and let's make electrolyte easy. So these are the outlines. This is the outline for presentation. It's we're going to talk about introduction, why electrolytes matter, key electrolytes, their role, range, imbalances, interaction, and clinical connections. We will also review a few NCLEX style questions just to get an idea about how they conduct NCLEX style questions and what to look for, and some key takeaways. So, electrolytes are ionized minerals that maintain cellular function, fluid balance, acid base, homeostasis, nerve conduction, muscle contraction, and cardiac rhythm. Imbalances disrupt homeostasis, and we know homeostasis is so much important. We always talk about it. It's often leading to life threatening complications like arrhythmias or seizures. Symptoms overlap due to shared effect on the central nervous system, neuromuscular system, and cardiovascular system. Like confusion from altered membrane potentials or weakness from impaired ATP production. Um, there are two types of electrolytes. One is extracellular and intracellular. Extracellular electrolytes are like sodium, um, and it dominate plasma, regulate osmotic pressure and fluid distribution. Intracellular electrolytes are like magnesium and potassium. It's concentrated inside the cell, support energy metabolism and excitability. Osmolarity and fluid shifts. Those are the two things that we mainly see when it comes to the relation between electrolytes and cells. Sodium drives water movement, imbalances cause edema um, or dehydration. We will see this later on coming slides. Or we can also see acid base buffering, mainly chloride and HCO3. Those are the two things, those are the main components that regulate pH. We are shifting between plasma and cells. Hormonal regulation, parathyroid hormone, aldosterone, or vitamin D modulate levels. Um, the renal role. So, when it comes to kidney, how it works, kidneys filter and reabsorb electrolytes. Kidney play a very important role when it comes to managing and um, how to balance electrolytes. That's the word I'm looking for. How to balance electrolytes. Kidney play a very important role there. Kidney filter and reabsorb electrolytes. It For example, if there is any dysfunction for kidney, if there is any chronic kidney disorder, for let's say, it causes retention, so hyperstates. So if we having kidney issues, it's not gonna filter electrolytes, so it's gonna retain all those electrolytes in the body. So you we will see hyper states, hypernatremia, hypercalcium, hypermagnesium. So these are the things happen when it comes to kidney disorders. Again, electrolytes are like body spark plugs: sodium, potassium, chloride, magnesium, calcium, and phosphate keep everything running from your heart to your muscle. The our NCLEX is very, like NCLEX is very tricky, right? It loves testing imbalances. It love asking us questions about electrolytes to test our knowledge, to test us about, um, if we know the difference between electrolytes, if we know the difference, if we can spot the difference, um, between different electrolytes, right? And because the symptoms overlap, like confusion or weakness, as I mentioned before, our job is to spot what's the unique and know their connections. There are some mnemonics that we can use, that I used to use in school, which helped me remember these electrolytes. Sodium, we all know it's for fluid balance. Potassium, we all know it's cardiac function. Whenever you see potassium, potassium is very sensitive electrolyte. When you see potassium somewhere and it's talking about heart, you would know which electrolyte is affecting that. Potassium is for cardiac function. We never push potassium in patient's body. We always administer it slowly because it really affect the cardiac functionality. We will talk about it later. Chloride, as I mentioned before, is for pH balance. Meg is for neuromuscular spark. Calcium is for our bone. As you know, it's muscle and membrane glue. Phosphate is for muscle and RBC power, red blood cell power. So first, we're going to talk about sodium, which is our fluid balancer. Sodium is the primary extracellular cation. As I mentioned in a previous slide, that it's the extracellular electrolyte, accounting for 90% of plasma osmolarity. It regulates extracellular fluid volume via osmosis. Water follows sodium. Always remember, wherever sodium go, water always follows that. If kidney filter out the sodium, water will go with the sodium out of the body. The sodium, famous sodium potassium ATP pump, maintains gradients: high sodium outside, high potassium inside the cell. um, Role, what's the role of sodium in nerve and muscle? Is depolarization. Depolarization relies on sodium influx. Imbalances alter action potentials. As I will talk about it maybe in another video about sodium potassium pump. If maybe you already know about sodium potassium pump, how it works, like when sodium potassium go in and out of the neurocell, it generate action potential, right? um and the imbalance of sodium alters the action potential, so it's not going to pass the message from one neuro to other neuro, just to put it in a simple language. Um, and kidney, the as I mentioned before, kidney regulates the sodium. Um, if you know, kidney is also responsible for RAS system, renin, aldosterone, angiotensin system. Um, ADH is for water retention, affects dilution, and thirst mechanism. So whenever it comes to sodium imbalance, always remember that it will affect fluid balance in our system. So there are two things that we will see in every electrolyte. I would say hyper and hypo. Hyper is extra, more, hypo is less than it's required. So as you can see, it's given on the slide. The normal range for sodium is 135 to 145. So hypernatremia, natrium, as per the periodic chart, sodium, we call it natremium. That's why it Na resembles sodium. So hypernatremia, if it's more than 145, we will see water deficient, so dehydration, or sodium excess cells shrinks as water moves out, causing CNS symptoms, so central nervous system symptoms. Um, if you remember from your school, we used to um, they used to teach us something about cells in the water. So if we put cell in a salty water, the water will come out of the cell, because as I mentioned, water always follows sodium. So sodium is out of the cell, so water also gonna come out of the cell. But if we put cell in a normal water, there's no sodium, there's no trace of sodium, or less than what's inside the cell, the water gonna follow the sodium which is inside the cell, and the cell going to burst at some point because water is keep going inside the cell. And in the other situation which I mentioned before, which sodium is outside the cell, so the water is full of salt, the the water come out of the cell is going to feel dehydrated and it's going to shrink. So same situation here. In hypernatremia situation, the sodium is outside the cell, so water going to follow the sodium and cell going to shrink and cell will feel dehydration. Okay. Causes is hypovolemia, like diarrhea, vomiting, burns where there's a loss of water. In diabetes, there is a free water loss because diabetic people pee a lot. um, and increased insens- in, insensible losses. I'm sorry about that. Like fever, tachypnea, where people lose water. It's not always like people. If some, for example, I have a fever for short term, I will feel dehydrated for that short period of time. The symptoms are thirst, restlessness, confusion, seizures. So always remember, when it's hyper, you will see low symptoms. So like thirst is low water, restlessness, confusion, seizure, our body feels low, right? Um, Unique is dry mucous membrane, flushed skin, um, overlap. I'm sorry about my dog, everyone. So yeah, I was talking about hyper situation when it comes to sodium. So we will see uh, dry mucous membrane, dry mouth, flushed skin, lethargy, and opposite to hypo situation. As I mentioned, when it comes to hyper, you will see lower symptoms. Um, when we talk about hyper, and when we see hypo, we will see confusion, headache, seizures, cerebral edema, muscle weakness, and we need to correct it slowly. If you administering um, sodium chloride, let's say, you need to administer it slowly to avoid osmotic demyelination syndrome. Um, when there's just mild difference with the normal range, We usually apply fluid restriction, or we give them isotonic saline. When there's a significant difference, we would administer hypertonic, which is 3% saline, with loop diuretic. Um, the great example, if I give you to explain the whole situation, um, marathon runner with excessive water intake um, will have hyponatremia from dilution, because they are taking a lot of water in short period of time, and they will have confusion, seizures, and the intervention would be hypertonic saline slowly, and we have to do neuro check frequently. The connection of sodium and chloride is their friends. They move together for fluid and osmotic balance. Check chloride in sodium imbalances, because if the sodium is low, chloride would be low. If um, the sodium is high, chloride would be high. Okay, and for NCLEX, my tip would be focus on fluid status. Hyper would be dry, thirst, hypo would be wet, edema, as I mentioned before, and distractor is confusion, because it overlap with so many other electrolyte imbalances, but edema is unique to hypo um, in sodium electrolyte imbalance. So next in our bucket is potassium. Potassium is the reference range is 3.5 to 5 mmol. High alert electrolyte, as I mentioned before, small changes cause cardiac instability. Sodium is a primary intracellular cation, maintaining resting membrane potential via sodium and potassium pump. The same thing that I discussed before when we were talking about sodium. Sodium potassium pump help in action potential generation. It regulates repolarization and muscle contraction. Maybe I will create a different video for sodium and potassium pump and how the action potential generates, because that's also very interesting and huge topic. Um, so I will create a different video for that. It regulates cardiac repolarization and muscle contraction, as I mentioned, and it's the major role in heart is it influence action potential duration. Imbalances alter ECG. Uh, you will see T wave difference, as you can also see in the picture here. Um, in ECG, you can, just to give you overview, you can see PQRST waves that resembles our atrium and ventricular contractions. And when comes to potassium imbalance, you will see T wave changes. The regulation is through kidneys. Aldosterone promotes excretion, as I mentioned before. Kidney plays a really important role when it comes to um, electrolyte imbalance. So So, just like sodium, we have two um, distinguish up and downs in potassium as well, which is hyperkalemia and hypokalemia. Hyperkalemia, when it's higher than 5 mmol, membrane depolarization slows, risking asystole. Um, The causes are renal failure. If we have chronic kidney disorder, it decreases the excretion. Cell lysis, trauma, which lead to cell death. Medication like ACE inhibitor, um, that block aldosterone, um, and which is spirolectin, like a diuretic, um, that cause potassium, um, cause hyperkalemia. Sorry, because the potassium sparing diuretic, the job of that diuretic is to keep potassium in a body, but that sometimes works in the opposite direction. It causes the hyperkalemia. So the symptoms are weakness, paralysis, arrhythmias, because if there's a lot of potassium in the body that affect our cardiac activity. The unique is, as I mentioned before, peaked T waves, widened QRS on ECG. So on ECG, you can clearly see the difference when the T wave is higher, and it overlaps with the bradycardia with hyper magnesemia, opposite to hypo. Always always clearly you can see the difference between hypo and hyper situations. And if you remember one symptoms, then you will clearly see the difference for the other one. The treatment for hyperkalemia, our main focus is to stabilize heart. So calcium gluconate IV, which is antagonize the potassium at the membrane. So the receptors on the membrane where potassium go and attach itself, the calcium, when we administer calcium gluconate, it's just gonna go take the place of that potassium, so it would not be able to go and attach itself to that receptor, and it shift potassium, um, and excrete through the body, from the body. um, we never push medication um, when it comes to electrolyte management. Case example, if we want to take an example to explain it in a better way, is CKD, chronic kidney disorder patient on ACE inhibitor will have hyperkalemia from retention. Symptoms would be, of course, peaked T waves, weakness. Intervention would be calcium gluconate that we administer, and we always have to monitor ECG for patients who have issues with the potassium. We have to attach them to cardiac monitor. And in terms of hypokalemia, membrane hyperpolarization, when the value is less than 3.5, it causes prolonged repolarization, causing weakness because we don't have enough potassium to generate action potential. Nerves are not working. The nerve cells are not working, not transferring messages, not generating ATP, and that's going to cause weakness. They're going to feel weak, right? Causes GI loss, vomiting, diarrhea that cause the potassium loss, renal losses, diuretic. If patient is on severe diuretics for any situation, we have to monitor their potassium. Not only potassium, I would say every electrolyte, but potassium is the serious one. So we have to keep an eye on that. And um, uh, the refeeding syndrome. maybe we will talk about it in future at some point. But refeeding syndrome is when someone is not eating from so long time, and suddenly we give them some kind of food or some kind of nutrition. We provide some kind of nutrition to them. That person, of course, will have less potassium in their body. um, and the symptoms of hypokalemia is cramps, constipation, arrhythmias. Unique is U wave flattened. Um, in the previous one, we were in a hyper situation, we were able to see um, T wave peaked, right? But in hypo, we will see flattened T wave and U wave. So you will be able to see that difference on ECG sheet. Um, the so easy way to remember, um, the hypo is opposite to hyper. Hypo is flat, depressed heart. Hyper is peaked and excited heart. So ECG is a really good way to see the difference. And treatment would be, if it's really mild, we give them oral potassium, KCl supplements. And there are food, there's a picture on the slide which has food components rich in potassium. And if there's a significant difference, we would give them IV potassium, 10 to 20 per hour. So it's like really small um, thing contain that potassium. And we you can see 10 to 20 is a really small amount, but because we have to give it really slow, we will give it per hour. Diluted, never, never, never ever push, um, because of the risk of arrhythmias. Monitor ECG, as I mentioned, we have to put the monitor just beside the bed of the patient to monitor um, ECG. We also have to replace MEG if it's low. Um, so we usually give it through central line for high doses. The case example for hypo is patient on loop diuretic. Um, it's a it's a kind of diuretic that we usually give if person has is in a situation of hypervolemia, and that cause hypo potassium from high excretion. And the symptoms are cramps and U waves, flattened U waves, and we would give them slow IV potassium, and we would ECG monitoring. The potassium and MEG, you must be thinking she's also talking about magnesium. We also have to focus on that when it comes to potassium, because they are connected. They are Potassium and magnesium are heart team. Low magnesium worsen hypokalemia. Acidosis shifts potassium out. Alkalosis in hypo situations. So NCLEX tip: always prioritize ECG monitoring. Put the ECG monitor beside the patient's bed. Then we need to connect them to ECG monitor. And weakness overlaps, but ECG changes are unique. So you will see if there's an issue with the potassium, you will clearly see that on ECG. Next is calcium. We always talk about calcium, that it's important for our bone, important for our teeth formation, for our blood clotting, muscle contraction, nerve impulse transmission. The reference range is 8.5 to 10.5. The calcium is 99% in bone, 1% in plasma, half bound to albumin, half ionized and inactive form. Ionized calcium regulates excitability by stabilizing membrane. Low calcium increase sodium influx, causing depolarization. Role in contraction: it binds to troponin in muscle fibers. Um, it also in clotting. It plays role in clotting factor formations, and it helps in vitamin absorption. um no, sorry, not the vitamin absorption, but vitamin D plays important role when it comes to calcium. We will talk about it. Hypercalcemia, it reduce excitability. As I mentioned, hyper means something low in our body, low symptoms. Hypercalcemia, you will see bone pain, fractures. um, okay, if we think about hyper means a lot of calcium in our body, and where that calcium coming from? It's coming from our bones are depleting to generate that calcium. Bone depleting means our bone are getting weaker, so you will see bone pain, fractures. You will see kidney stones because there is a lot of calcium in our body, and that calcium trying to bundle up and try to go into some corners, or because kidney also excrete our electrolytes, so that calcium bundles up and store itself in kidney, so it creates stones. Lethargy, weakness, shortened QT intervals, so you will see that on ECG. The cause of hypercalcemia is hyperparathyroidism. Parathyroid is a gland just beside the thyroid gland, which controls calcium. If there's hyperparathyroidism, hypergeneration of parathyroid hormone, um, it will cause the bone resorption, malignancies, immobilization, bone breakdown, vitamin D overdose. Vitamin D. So vitamin D helps body to absorb calcium. If vitamin D is less, body will not gonna absorb calcium. So vitamin D, if we take excess vitamin D overdose, will cause hyper situation. Acidosis, and the symptoms are um, bone pain, fractures, confusion, weakness. The unique is kidney stones, as I mentioned before, and shortened QT wave in our ECG. Um, the overlap is lethargy with hypermagnesemia. Opposite to hypo, the hyper suppressed. So you will see the in hyper you will see low symptoms, something negative happening, less um, stuff like bone fracture, pain, something negative, right? And in hypo, something high, excited. um, so yeah, calcium is always connected to bone. And so you will see bone pain, nausea, vomiting, um, overdose vitamin D, as I already mentioned. um, and on if we talk about example, cancer patient with bone metastasis will have hypercalcemia because their bone are continuously depleting. And symptoms will, as I mentioned, bone pain, confusion, Intervention, fluids, we need to give them fluids, bisphosphonate, and monitor their calcium level. The hypocalcemia is less than 8.5. The range is 8.5 to 10.5, so it's less than 8.5. In this situation is opposite, so hypoparathyroidism causing less calcium, because parathyroid is not able to make enough hormone that let our body know that we have a less calcium in our body, we need more. So hypoparathyroidism cause that, and it could be because of the thyroidectomy. So some people has to remove their thyroid gland because of they have issues with thyroid. I don't want to go deep into that. Vitamin D deficiency, so it's not observing, body is not observing enough calcium. Renal disease, alkalosis, hypomagnesemia. So calcium and magnesium both are connected to each other. If person suffering with severe alcohol disorder, symptoms would be paresthesia. um, Paresthesia is mouth, the skin around mouth um, feel numb, or you would not be able to feel it. And hyperflexia, cramps, Chvostek's and Trocher's signs. So you will see their hands are not able to move when they bend. um, Seizures. Unique is prolonged QT. So paresthesia, Chvostek's, sorry if I'm pronouncing is incorrect, pronouncing the word incorrectly, or Trocher's, these are also unique signs of hypo. When you see these signs, is because of the hypocalcemia. There's less calcium in the body. And prolonged QT is one of the sign. It overlaps with the confusion of hyponatremia, but always look for these unique signs. um, and it's opposite to hyper. Hypo is excited, hyper is suppressed, as I mentioned before. The a good example here would be post thyroidectomy. As I mentioned, some patient who have issues with thyroid, they have to remove their thyroid gland. So after that, people also have issues with their parathyroid glands, or they are not, because their body is not able to get enough hormone. And they will have hypocalcemia, and they will have tingling around their mouth. And um, we have to monitor their QT level, and we have to give them IV calcium. um, and connection of calcium and magnesium, as I mentioned, they are connected, they are friends. Low magnesium, low calcium; high magnesium, high calcium. And the NCLEX tip is we need to look for unique signs for hypo, and there are unique signs that will let us know that this is the hypo situation. Next is magnesium, and the role of magnesium is a neuromuscular regulator. The range is 1.5 to 2.5. Magnesium is the second most abundant intracellular cation, blocking calcium channel to regulate excitability. It activates enzymes for ATP production and PTH secretion, parathyroid hormone secretion. ATP is, I call it energy molecules. And the role in neuromuscular, it suppresses acetylcholine release. Low magnesium increases excitability. We need to regulate, for the regulation, kidneys reabsorbed in the magnesium, it reabsorb magnesium, um, or it excrete magnesium. GI absorption, or excretion, and there similarly, just like others, we have hyper and hypermagnesemia, higher than 2.5. It suppresses neurotransmission. The cause is renal impairment, decreased excretion, excessive intake of antacids, to reduce the acid productions, or if someone is suffering from acidity, um, or someone is getting IV, um, magnesium sulfate for preeclampsia, they will have hyper magnesemia if we do not monitor it well. And overdose in elderly, with poor renal function, um, if their kidney is not able to excrete well and they take it more than they need. The symptoms are bradycardia, hypotension, weakness, like low symptoms, and lethargy, coma, if it's really severe. The unique is rest depression. The overlapping symptoms are lethargy with the hypercalcemia. Opposite to hyper is suppressed, slow, as I always mention. Hypo is excited and fast. Um, the mnemonic that I always use to keep it in my mind is slow. So suppressed reflexes, lethargy, overdose. We need to watch kidneys. Treatment is loop diuretic. So we want to excrete extra magnesium from the body. So we will take diuretic. Fluids to excrete. Plus we need to drink a lot of fluid. And calcium gluconate IV, um, to antagonize the magnesium. We also do dialysis for severe, if people have a kidney disorder and they are not able to excrete it, so then we have to get the emergency dialysis. And we need to stop all kind of magnesium sources. So you can see the food sources that I mentioned on, there's a picture on this slide. These are the food that we take for magnesium. We have to stop taking all of those, so we are not putting extra magnesium in our body. Case example is preeclampsia patient, as I mentioned, take magnesium sulfate, and they will have hypermagnesemia, and symptoms would be bradycardia, um, and rest depression. So we are looking for, and we want to stop infusion, calcium gluconate. We need to give them through IV and monitor breathing. The opposite situation is hypomagnesemia. It is less than 1.5. Happens due to GI loss, diarrhea, or Crohn's disorder, Crohn's disease. Diuretic, if they are taking a lot of diuretic and they are not monitoring their electrolyte, they will have hypo situation. Alcohol use, because when people take a lot, they drink a lot of alcohol, they have to go pee a lot, and that cause a decrease in the level of electrolytes. um, Refeeding syndrome, symptoms would be tachycardia, hypertension, twitching, hyperflexia, confusion. So in hypo we will see excited, fast, severe symptoms. And the unique is a positive Treasure's sign with hypocalcemia. So because they are friends, so hypomagnesemia magnesemia means hypocalcemia, hypermagnesemia is equal to hypercalcemia. So we will see same kind of symptoms. And the overlapping is arrhythmias with hypokalemia. That's the overlapping symptom, but we don't want to focus on that. We want to see the unique symptom. Always look for the unique symptom. Make a note or a flashcard with the unique symptom, because that's they are going to ask. They are not going to put you in a situation where you are not able to differentiate well. There will be um, unique symptoms you will see in questions that will help you identify the difference. And opposite to hypo is excited fast, and hyper is suppressed and slow situations. I'm keep repeating that so that it stays in your brain. And the treatment would be, if it's mild, then we take oral magnesium oxide or magnesium sulfate, but it may cause diarrhea as well. um, IV magnesium sulfate slow infusion. We always have to slowly infuse, and replace calcium if it's low, because both are friends. If meg is low, that calcium would be low. If the meg is high, calcium would be high. So we also need to monitor calcium. The case example is alcoholic with malnutrition, will have hypomagnesemia. As I mentioned before, alcoholic people has to go pee a lot, and we will see lower electrolytes. And symptoms would be twitching, tachycardia, and our classic um, the hypocalcemia signs. So slow IV magnesium sulfate, monitor ECG, and check calcium as well. As I keep mentioning, magnesium and calcium both are friends. Low meg, low cals, and vice versa. So NCLEX tip focus on the classic signs um, of hypocalcemia, which is also classic sign of hypomagnesemia. Next is chloride. Chloride is a major extracellular anion maintaining electrical neutrality with sodium and calcium. It regulates blood volume, pressure via osmosis, and pH via the calcium and bicarbonate shift. Inverse exchange in kidney and red cells. So when it I don't want to go more deep into it, but chloride and bicarbonate, they both works together. They are actually opposite, but they works together to manage pH balance. The role in pH in acidosis, the chloride enters plasma as bicarbonate go out and decreases. In alkalosis, chloride enters cells as bicarbonate increases. And regulation is through kidneys, parallel to sodium reabsorption. GI tract is also helpful in controlling the level. Hyperchloremia, often with hypernatremia or acidosis. Um, we will see dehydration, excessive saline, IV. These are the causes. Dehydration is the cause, excessive saline is the cause, renal tubular acidosis, impaired bicarbonate reabsorption. If there's we are not able to reabsorb bicarbonate, we will see signs of the hyperchloremia. um, Compensation for metabolic acidosis. If we are not able to manage chloride, we will see the pH difference. Symptoms are tachypnea, respiratory compensation for acidosis, because chloride is not in a good situation. Our pH balance is not in good situation. We having acidosis in our body, so our respiratory function will try to compensate. So we will try to breathe a lot to throw that carbon dioxide out to decrease the acid level in our body. Maybe we will talk about this whole compensation in coming videos as well. Um, and it also causes weakness, confusion. The unique feature is hypertension if it's correlated with sodium. The overlapping is lethargy with hypermagnesemia, but we're gonna find the unique feature as always, which is tachypnea to manage the pH balance. So the treatment is treat cause. So stop saline, correct acidosis with IV bicarbonate. Fluids, we would give them hypotonic to dilute the chloride, diuretic if volume overload to reduce the volume from our body to throw the extra fluid out. And we want to monitor pH, which is very important with chloride. um, the case example: patient on excessive normal saline IV will have um, hyperchloride in their body with acidosis. And symptoms are, as always, tachypnea, and intervention switch to bicarbonate to manage the pH and containing fluids. We want to give them more fluids and monitor their um, blood gases, ABGs. The other one is hypocalcemia, often with hyponatremia or alkalosis. The cause of that is vomiting, where we lose the HCl, the acid, or stomach acid. Diuretic and metabolic alkalosis. um, the compensation of it compensate for respiratory acidosis. The symptoms are muscle cramps, tingling, alkalosis. The unique symptom of hypochloremia is hypotension if it correlates with sodium. The overlapping is cramps with hypocalcemia, but we want to find the unique feature as always. So we will go by the pH, which is metabolic alkalosis, and the vomiting and GI suction cause that because we are getting the HCl out of our body, the acid, the stomach acid, um, which causes the hypo situation. The treatment would be normal saline IV to replace chloride, ammonium chloride for severe cases, and treat the underlying cause. We always want to treat the underlying cause, because if you're just treating the, for example, there's hypo situation, hypochlorite situation, we are just keep giving the chloride from outside to our body, but we are not managing our underlying cause. It's keep gonna happening, right? So to find the long-term solution, we want to treat the underlying cause. The If we want to talk about the case example, patient with prolonged vomiting, for any case, for example, pregnant person having nausea and vomiting, and they are keep continually vomiting, that's going to cause the hypo situation, right? And we will see the classic hypo signs, which is alkalosis, and we will see cramps as well. So intervention is monitor pH and normal saline IV. You want to give it from outside. But think about it, use your critical thinking here. What do we want to do to treat the underlying cause? If pregnant person having nausea and vomiting, and that's causing the hypo chloride, what we want to do here? We want to keep giving them chloride every time when they have this situation? No, we want to try giving them something for their nausea and vomiting, antiemetics, right? So we want to treat underlying cause. So chloride and sodium are friends, right? It moved together. Chloride and bicarbonate are opponents because they are pH buffering. One go in, one go out, one the other one go out, the other one go in. So that's how they manage the pH. I'm not sure if it's making sense. Um, but maybe I will include that in my notes under the video. That will be helpful, and you can go through those notes again. The NCLEX tip here is linked to pH. Hyper is acidosis, and they will have tachypnea because they want to throw the carbon dioxide out. Carbon dioxide is acid to manage the acidosis. The hypo is alkalosis, and they will have cramps, right? Distractor is confusion overlaps, but pH shifts are unique when it comes to chloride. Okay. The next is phosphate. The range is 2.5 to 4.5. Some people also consider 3 to 4.5, which is very minimal difference. The phosphate is 85% in bone, 50% in intracellular. It buffers pH and activates enzymes. The role of phosphate is muscle and red blood cell management. um, the ATP for contractions. um, Vitamin D, if it increase the absorption, that also cause the phosphate imbalance. Kidneys reabsorbed, if kidney, as I mentioned, it helps in managing our electrolytes. um, and I will explain the vitamin D, how it's connected to phosphate. So hyperphosphatemia, hyper, so um, low, slow symptoms, often due to renal failure. People will have hyperphosphatemia because it's not excreting extra phosphate from our body. Calcification of soft tissues. They will have itching on their body because there's a lot of phosphate building up under the skin. Symptoms related to hypocalcemia. Hyper, just to let you know, phosphate and calcium both are related, but not as friends, they're opponents. So when you have hyperphosphate, you will see hypocalcemia. When you have hypophosphate, you will see hypercalcemia. That's how the vitamin D is connected to phosphate. If you can make that connection of vitamin D to calcium and calcium to phosphate. So the cause of hyperphosphatemia is renal failure, decreased excretion, hypoparathyroidism, low parathyroid hormone, retention of calcium, and that cause the hyperphosphatemia because there is hypocalcemia. Cell lysis, laxatives, excess intake of phosphate. The symptoms are, as I always already mentioned, hypocalcemia. They will have cramps, tetany, all the signs of hypocalcemia, and they will have depression, anxiety, calcification. Unique is itching. Calcium phosphate deposits under the skin that cause itching of your skin, on your skin. Overlapping symptom is anxiety with hypocalcemia. And the easy way to remember is hypocalcemia, intake excess, give binders, handle calcium deficiency. Treatment is phosphate binders. It's For example, we want to give them medication that bind with the phosphate and excrete it out of the body. So that's the phosphate binder. And we want to handle calcium deficiency. We want to treat hypocalcemia to treat hypercalcemia. Dialysis for renal failure if they're having issues with the kidney. And good example is CKD patient, chronic kidney disease disorder patients. Will have hyperphosphatemia because they are not able to excrete it from the body. And symptoms are cramps. Itching is really good differentiating symptom. And the intervention is binders, and we want to give them calcium because they have low calcium. um Hypophosphatemia impairs energy production. ATP molecules are energy molecules. Malnutrition, poor intake, alcohol withdrawal, urinary loss caused by alcohol. Antacids, when they take a lot of antacid, it bind with the phosphate and excrete from the body. Acidosis shifts refeeding symptoms would be confusion, weakness, decreased GI motility, um, and you will see constipation in these patients as well. The overlapping symptom is weakness with hypokalemia, but you always want to find the unique one. And the unique one here is decreased GI motility. Confusion is also, you can take it as unique. um, and the treatment is oral IV phosphate. We want to give them orally if it's really mild. And if we want to give them IV for severe, we want to give it slowly. Monitor calcium may cause hypercalcemia, and you will see hypercalcemia signs there. um Case example: alcoholic patient in withdrawal will have hypophosphatemia, and symptoms are weakness. Intervention is IV phosphate if it's really high, and we want to monitor calcium because they are not really good friends, they're opponents. So phosphate and calcium are opponents, inverse relation between both of those. And NCLEX tip is linked to calcium. If hyper, you will see hypocalcium. If we have hypophosphate, you will see hypercalcium. Distractor in this whole situation is weakness overlaps, but hemolysis is unique in this whole situation because phosphate is connected to RBC. Okay, so these are the ones I included on this slide just to make the connection between all the electrolyte. This is how I used to remember to find out the unique signs. So you can see calcium and phosphate as we already discussed. If one up, the other down, so you can see the inverse relation between both of those. Sodium calcium are friends. Sodium and chlorides are best friends, holding hands. Potassium and magnesium guarding the heart. They both are connected to heart situation. Bicarbonate and chloride is our balancing pH team. This talks about the same thing, but it gives us the difference of each and every. So just to keep in mind, sodium is our fluid balancer. It controls water in the body. Potassium is heart protector, so keep heart beating smoothly. Calcium is our bone and muscle stabilizer, building bones and muscles. Magnesium is our neuromuscular regulator, calms nerves and muscles. Chloride is our acid base partner with bicarbonate. It balances pH with sodium. Um, and phosphate is energy and bone builder. It fuels ATP or energy molecules and strengthens bone. Bicarbonate is not really part of this, but because it's connected to chloride, it's a pH buffer and keeps blood pH stable. This whole chart talks about the same thing, and you can use it in your notes, or you can put it on your flashcard. For NCLEX success, this is our destination. Putting it all together. Think holistically. Electrolytes really act alone. Consider their interconnections and ripple effects, how they are connected to each other, or what's the relation with the other electrolyte. We want to practice in NCLEX question. I also included few NCLEX questions on this video that will help you to practice, and you would know what kind of questions we need to expect, and we want to apply our knowledge there to identify the difference. Monitor vitals and labs. Always correlate signs and symptoms with lab values and patient history. Identify risk factor. Recognize patterns at risk. Patients at risk. Renal disease, diuretic, GI loss. If they're having any kind of issue with the kidney, with the GI, where the extra stuff from our body is going out of our body, if there is issue with those areas, they will have issues with the electrolytes. Understand interventions, know the appropriate nursing and medical management for each imbalance. Okay, let's go ahead and check few NCLEX questions. A nurse is assessing a client with suspected hyponatremia, hyposodium. Which manifestations should the nurse expect? Select all that apply. So when we have hyponatremia situation, hypo means fast, severe, high symptoms. Okay, so take a minute here and see what you're looking for when it comes to hyponatremia. Okay, so correct answer is A and D. So A is confusion and seizures, D is cerebral edema and headache. Okay, hyponatremia, low sodium, causes neurological symptoms like confusion and seizures. Um, Seizures, high activity in our body. A, the cerebral edema and headache, due to the D is due to the water shifting into brain cells, which cause the edema. Muscle weakness and U waves are associated with hypokalemia, if you remember, not hyponatremia. And lethargy indicates hypernatremia because it's weakness, it's weak, it's low, tired, which is connected to hyper situation, the opposite imbalance. Okay, the other one is a client with the chronic kidney disease is at risk for hyperkalemia. Which intervention should the nurse prioritize? Select all that apply. Look for the all the options that we have and think about it. Okay, correct answer is A, B, and D. Hyperkalemia requires Ca² to remove excess potassium. It's a kind of diuretic, so that will help us to remove excess potassium from our body. We want to monitor ECG for peaked T waves indicating cardiac risk. Potassium always connected to cardiac risk, and checking magnesium because it's connected to magnesium due to the potassium magnesium heart team connection, as low magnesium worsen hyperkalemia. Encouraging bananas. Banana is um, the source of potassium. We would increase potassium intake. That will worsen the condition. If we take more bananas, more potassium in our body, that will worsen our situation. A nurse is monitoring a client receiving IV magnesium sulfate for preeclampsia, the same example that we discussed before. Which action should the nurse prioritize? Take a minute, think about it. Administer calcium gluconate as ordered, or monitor breast rate and reflexes. What do you think we should do? Okay, the option B is the correct answer. Monitor rest rate and reflexes. Magnesium sulfate can cause hypermagnesemia, which lead to respiratory depression, as we discussed before. That's the unique sign of hypermeg. And decreased deep tendon reflexes, both life-threatening signs. Um, Monitoring these is a priority to detect toxicity earlier. Calcium gluconate is an antidote for magnesemia, but is not the first action unless toxicity is confirmed. Which, if for example um, the level is really small, very mild, we don't want to do that. Okay. Um, and encouraging oral fluids in is appropriate during preeclampsia treatment due to fluid overload. Magnesium and potassium are linked together, so monitor potassium if arrhythmias occur. Sodium levels are unrelated to magnesium therapy because they are not connected to each other. All right, that's all for today. Thank you so much for listening. And if you have any questions, you can post those questions in your comments. If you have any recommendation, if you want me to make a specific video on any specific topic, you can post it in comment. Please like, share, and subscribe. I'm here to answer any question about nursing, about how to enroll ourselves in nursing program, what are the eligibility requirements, how the whole thing works, what to expect for those 4 years in nursing. I'm always here to help. um, and thank you so much for watching. Have a good one. Bye.